All right, here we are on lecture number 2 of the cervical pathologies. And this one, we're going to be looking at strains, sprains, and facets. Strains, sprains, and facets. Really, really common stuff here. So, looking at strains, in this class, am going to diagnose strains as damage to contractile tissue, right? And so that will largely include tendinopathies, which are similar yet slightly different from a muscle tear. They're similar in that they're roughly going to be diagnosed the same way, right? And a lot of the same mechanisms create tendinitises and tendinopathies as do actual tearing to the contractile elements of a muscle, right? And the reason I define strains versus sprains is largely because of healing time. Strains tend to heal, damage to contractile tissue tends to heal faster than damage to non-contractile tissue, and that has a lot to do with the amount of vasculature that is within that tissue itself. So, strains, otherwise known as pulled muscles or muscle tears. Excuse me. So that's going to be tearing or damage to contractile tissue. There's 3 basic grades of it: mild, moderate, severe, grade 1, 2, 3, however you want to call it. But this is a nice little image over here, grade 3 being like a complete rupture of a muscle or tendon. So that's not generally a great place to be, and generally that will be a longer healing process. But these grade 1, grade 2s can heal really, really quickly with the right therapy applied to it. Symptoms, so there's generally going to be local pain, may radiate, kind of like the trigger points that we were talking about in the previous lecture. Generally worse with activity. Makes sense, right? You damaged a muscle, you use the muscle, it hurts, right? So you might see some swelling and bruising with the more severe types of strains, and there might be some limitation of range of motion due to guarding, right? So how do you get this? Trauma. Maybe you overstretch or overactivate something, or overuse. Those are probably going to be the 2 most common ones. Trauma. So this, even though there's not like a baseball bat or a car wreck or something hitting this back, this is like a classic way you strain your back, right? Muscles become very vulnerable when they're in a lengthened state and they have to contract, right? So frequently when you bend at the waist, you are lengthening the muscles, and then you create a contraction on a lengthened muscle, especially with a large counterweight or excessive weight, more weight than that muscle is designed to hold, and boom, you end up tearing it, right? So that would be a traumatic result. Or postural straining, like you're just constantly looking down at your phone, and these lower cervical, upper thoracic muscles are just getting overstretched, as well as trying to hold the weight of the big bowling ball head up here for too long, and they start to tear and fatigue, right? So that would be a result of an overuse type of a strain. Right? Other ones are repetitive microtraumas or postural, which is ultimately going to be similar to like an overuse. That's not a good overuse. This is postural. I don't know why I said that was overuse. Overuse would be like going to the gym and working out too much, doing too much work and something like that. So those would be largely strains. So how do you diagnose a strain? Well, there could be a fair amount of ways, but I think the most reliable way to do it is resisted range of motion. Yes, you could use palpation, active range of motion, passive range of motion to do it, but the best way, if I ever ask you how do you diagnose a strain, what I'm looking for is resisted range of motion. What you are doing is you are not allowing a joint to move, but you are engaging the muscles around that joint, right? So I eliminate the movement component of a damaged area, and I just engage the muscles. It's a good way to isolate that motion, or isolate the stress to that one structure, the contractile element of that. So how do you treat it? Well, what is your goal? Specifically at this time with this patient. During acute phases, generally you're going to want to decrease the pain and control the inflammation, right? Subacute phases, generally you're going to increase your range of motion. In the chronic phases, generally you're increasing strength, right? How do you want to achieve that? Well, decreasing pain and controlling inflammation, there's a lot of ways to do that. You could do something like an ice or a pharmaceutical, or anything in between, right? When we get more to a subacute phase, increasing range of motion, I think stretching is a very, very easy thing to do. And then increasing strength, I would recommend resistance training. So that would be a very, very simple thing to do. But there's a lot of things a lot of different manual therapies that we can do to, say, increase range of motion, via helping some of the scar tissue or the healing tissues break apart, active stretching, right? Exercise therapies, that sort of thing. So those are some basic ways to treat a strain. Now, let's take a look at sprain. So sprain. Why is this not working? Okay, there we go. Sprain. So sprain is going to be basically the exact same thing as a strain, only it's damage to non-contractile tissue. Could be fascia. That's a bit of a stretch. We're going to stick with mostly ligamentous structures and or joint capsules. Cartilaginous surfaces. That's a bit of a stretch too. So we're going to say mostly ligaments and joint capsules is going to be what we're going to call spraining. But it's going to be diagnosed the same sort of way, or it's going to be classified the same sort of way. A first, second, third degree sprain, with the amount of damage to tissues, right? Is it a full-blown rupture, 100% damage? That's a severe sprain, right? Or did we do just a little bit of fraying of, say, part of a tissue, right? Generally, the symptoms are going to be the exact same as straining, right? There's bruising, swelling, potentially local pain, pain worse with activity, better with rest, limited range of motion, right? Generally going to be a result of the same things with strains. It's the same, right? These tissues are very, very similar. They're susceptible to the same forces, right? The difference is, once again, the amount of vasculature within the tissues, right? So most commonly, it's going to be traumatic. You roll an ankle, right? You are in a motor vehicle car accident, motor vehicle wreck, right? Where your tissues are being taken to an end range and beyond into a pathologic range of motion, right? Could be overuse. You're overstretching, SI joint, for instance, right? You're sitting for too long, or you're doing some sort of weird activity that's just putting constant stress on your sacroiliac joint, right? Or postural, same thing, sitting. I just did it again. I mixed those two up, right? Overuse would be like overdoing something. You are constantly bending a certain way over and over again. There's some overlap with these. And then those might lead to repetitive microtrauma, so weakening of the tissue. And then there may or may not be one sudden incident that kind of puts you over the edge. So in general, when we're diagnosing sprains, we're going to use passive range of motion. Yes, you could use palpation, you could use active range of motion, but I think the best test to do this in office would be passive range of motion, short of, say, imaging, for instance. So passive range of motion would be, that's the practitioner is going to guide a body part, a suspected body part, through a range of motion, looking at which directions are limited and or painful and which are not. Generally speaking, when we put the stretch on that tissue, that's going to elicit the pain response, right? Versus if I detension where I suspect the strain to be, I would not expect much of a pain response with that, right? So usually passive range of motion into a stretched position, right? Passive is nice because it eliminates the contractile element of it as much as we can, right? Is it possible to light up a muscle strain with passive range of motion? Yeah, it is. It is. But if we can get that muscle to relax and really isolate the motion to a specific joint and or ligament that we know, if we know the origin and insertion and the attachment points of those, we can really isolate the stretch to that spot, right? So it helps raise our suspicion of spraining over straining. So how do we treat it? What's your goal? What's your goal? Right? Acute phase. This is going to be very similar to straining once again, right? Decrease the pain, control the inflammation. Subacute, increase range of motion. Chronic, increase strength of associated muscles, right? Associated muscles in the area. Maybe help guard and protect that motion as that tissue heals up on its own, right? You could say maybe put more collagen or vitamin C in your system might help with the healing process, right? So there's a lot of ways you can do this. Very, very similar. The other thing, I can't remember if I put it on the last slide or not. If we're dealing with a full tear or rupture or an avulsion, you probably want to get some sort of orthopedic consult for that, because that might be a surgical fix. We might need help at reattaching a ligamentous structure to a bone. Okay, next thing I want to talk about is facet syndrome. So these are when the joints in your neck specifically, but this could happen in any joint, but we're in the cervical spine. So the joints in the neck become inflamed, right? So joint irritation, stiff neck, crick in the neck, mild to severe inflammation within a facet joint. Holy moly. I would say generally severe inflammation. This is one of those examples where the pain levels of this condition during an acute inflammatory response are through the roof. They're really, really they're really, really high, right? So this can generally cause a lot of fear within patients as well, right? Symptoms are pain, probably pretty severe pain, right? And it generally increases with joint compression and decreases with joint distraction, okay? And there is generally a pretty good limitation to range of motion. It's a classic, like slept on your neck funny, and then for the next, few days, you're doing the Batman turn, right? You're turning your whole torso when you're trying to look up, around, and do things like that, right? It's especially difficult, specifically like when you're driving. Like you can turn to the right, okay, but when you have to look over your shoulder left, you have to do this goofy thing where you're turning all the way down from your lumbar spine. I would wager most people have experienced this at some point in time in their life, right? Generally going to be a result of aberrant arthrokinematic. Could be trauma, could be overuse, but I think the most common thing would be an aberrant biomechanical move, otherwise called a sudden unguarded movement, like a little goofy movement in your neck, and you feel a little like, ooh, that was weird, a little pinch or tweak, right? A lot of times it happens first thing in the morning after you've been sleeping in a goofy position and your proprioception's all off and your muscles are all stretched to weird positions, and you go to move and you just pinch some of the joint capsule right away. And then over the next hour, it starts swelling and getting really bad. Local swelling, not visible swelling, but swelling in and around the joint. So I would say generally some sort of sustained posture followed by a sudden unguarded movement would be the most common cause. But it could be traumatic, right? Maybe someone lands on your head or you have some sort of compression injury or whiplash or something like that, right? So this kind of thing, ow, right? You're holding your neck. Of these two people here, I would say the woman in blue is probably more likely to be having a facet syndrome because she's leaning away from the pain. She's opening up the facet joints on the left side, where this woman in pink looks like she's leaning towards. So if this were a facet syndrome on her right side, she'd actually be compressing those joints. She probably wouldn't be doing that. This would be a position more for like a muscle strain, right? She's detensioning that muscle, right? So of these two, I would say this is more likely to have the facet syndrome, right? So diagnosis, how are you going to diagnose this? Passive range of motion. Could you do it with joint plays and active range of motion? Yeah, absolutely. But passive range of motion is the one that's going to help isolate this diagnosis, right? And the passive range of motion, you would expect when I compress the joint of interest, that hurts. And when I distract the joint of interest, that does not hurt, right? So it's a quick way of knowing. In the cervical spine, if it's a facet joint in the back, when I passively flex, usually that feels pretty good. And if I passively extend, usually that hurts, right? Because I'm compressing the joints on extension. Then if I bend to the right and it hurts on the right, it's a problem on the right side, right? If there's a problem on the right side and I bend to the left, usually that opens up the facets on the right, and that feels pretty good. So it's a way to isolate and tell at least what side and roughly where in the neck it usually is. What is your goal for treatment? Well, generally, we're going to only be in an acute phase to a subacute phase. There doesn't tend to be much of a chronic phase with this, right? Because once that inflammation goes away, the pain drops from like a 10 to like a 2 for maybe a week, and then it's pretty much gone, right? So decreasing that pain and controlling that inflammation is going to be your primary goal, right? Subacute phase, increasing that range of motion, relaxing the musculature, dealing with the joint dysfunction in the area, generally speeds the process up, right? And then for the chronic stuff, I put like increased proprioception, to reduce your sudden unguarded movements and decreasing contributing factors, watch your sleep posture and that sort of thing. How do you want to do this? Well, I think manual therapies work brilliantly here, obviously, right? But some sort of topical or internal machines are really nice for this, a little bit of electric stim or something, anything to reduce the inflammation is pretty nice. And I think pain education is a really good idea because people have a very difficult time understanding that the severity of pain does not match the severity of the pathology. And this is a prime example where there are 10 out of 10 pain, but the severity of the pathology is very, very minor. I mean, this will clear up on its own in a couple days, right? So this is a great learning experience, but it does take a little bit of education on your part. So that's all I got for these three.